I'd like to welcome you to this ESE Talks Nurse webinar on acromegaly. As I said a moment ago, I'm Sandra Hendricks, nurse practitioner from Houston, Texas. I'm on the nurses committee here with ESE, and I'll be chairing this conference today. We'll be starting with Professor AJ Vanderlei, who will give us an overview on acromegaly, and then we'll finish up with dynamic testing from Christine Yadanek. And our aim today will be to provide a virtual educational platform to support endocrine nurses' ongoing professional development, with focus on developing nurses' knowledge and clinical skills in endocrinology. And the objectives we hope to meet today is to provide an endocrine-specific training for nurses to develop a deeper understanding of the different endocrine disorders from diagnosis, management, and ongoing care. Number two, to support endocrine nurses in understanding and utilizing the endocrine competency framework in their clinical practice, and to use a framework to support ongoing personal and professional development. And our third objective today will be to provide a virtual platform for networking and support through educational events. So our nurses' competency number one is acromegaly, and it's developed by the Society of Endocrinology. And this is our second nurses edition. And in addition to English, it is now available in French, German, Polish, Spanish, and now Turkish. So this is our schedule. We are doing our introductions, and then we'll go in with Professor Vanderlei, who will talk about diagnosis and management. From there, we will hear Christine Yadanek, my colleague from Oregon, talk about dynamic testing. And if everyone can hold their questions to the end, I'll ask you to enter them into the chat box. And then at the end, we'll have a Q&A and close out and talk about our upcoming webinars. So with that, I'd like to introduce Professor AJ Vanderlei. He is head of Division of Endocrinology and Professor of Endocrinology at the Erasmus University Medical Center in Rotterdam, Netherlands. His professor has served as the president for a number of learned societies, including the European Society of Endocrinology, as well as positions on editorial boards of several journals. Thank you, Dr. Vanderlei. We'll turn it over to you.
Thank you, Sandra, for this very kind introduction. Hi, everyone. I don't see you, but you can see me, as I hope. What I'll try to do is give you an overview about how to look at the disease. And what I hope is that at the end of my presentation, you will look in a very different way to the disease and the patients, and maybe that will help you to understand why they complain about certain issues, why the treatment is focused on several issues, not only on the GH and IGF-1 concentrations. These are my conflicts of interest. It's a complicated slide, but as you all know, the disease starts because you have a pituitary tumor in the anterior pituitary tumor. Now, intriguingly, the anterior pituitary tumor from a fetal origin is not part of the brain, but part of the gut. So, in fact, you could say that the anterior pituitary tumors are gut tumors, and they behave a bit like endocrine gut tumors as well. Now, the pituitary adenoma, the somatotropinoma, that produces too much GH. That GH works on the liver, that starts to generate too much of a factor that is called insulin-like growth factor 1. And we come back to that a lot later on in my presentation. Now, the GH works on all tissues, kidneys, bone, and the adipose tissue, which is also true for the IGF-1. So the body encounters two hormones in a concentration too high, namely GH and IGF-1. Now, you all know that we have medical treatment modalities like somatostatins, and we call them somatostatin receptor ligands, octreotide, lanreotide, pasireotide, and dopamine agonists, bromocriptine and cabergoline. These two compounds work because they reduce the output, the production of the tumor GH. So the hope is that if you reduce the GH to a normal level, you will restore a normal IGF-1 as well. The other drug is a GH receptor antagonist, and the only available right now is a compound that is called pegvisomant or pegvisomant, and the brand name is Somavert. That's a completely different drug. It works as a blocker of the receptors that GH needs to activate the liver, the GH receptors. But the GH receptors are throughout the body. So this compound also blocks the receptors in the kidney, in the bone, in muscle, and adipose tissue as well. Now, in everyday practice, there are relatively cheap but not so effective medical compounds, and there are the expensive ones, and they are the most effective ones. The dopamine agonist, radiotherapy, and surgery are relatively cheap, but not the most effective ones. And the most effective ones, somatostatin analogs and GH receptor antagonists, are really expensive, but very effective. And in fact, nowadays, you can normalize everyone in their IGF-1 concentrations. Now, to understand why not all of the therapies are very effective, you have to realize that a rare disease brings in very different way of thinking. So this condition is very rare, to stand on top of your car that just fell over and finished in the harbor. So if you have a very rare condition, you have to bring in a specialist. And the specialists start working on the problem, but not all specialists really know the solution, and therefore not every specialist is the perfect solution. So if specialist A doesn't cure the patient, then we need specialist 2. And specialist 2 starts working on the problem, working on the problem, working on the problem, and sometimes is not able to, like solution number 1, solve the problem for the patient. And you need a third specialist. Why is that so important? Well, a whole set of specialists is needed to treat rare diseases, not only a specialized and very experienced endocrinologist, but also a radiologist and also the neurosurgeon. And what in fact all of them try to do is influence the mortality in these acromegaly patients, because a guy from New Zealand, Ian Holdaway, published about already 20 years ago a very important paper. And he showed that a reduction of GH to less than 1 microgram per liter or normalization of serum IGF-1 reduces mortality to the expected levels, meaning that the mortality, the longevity of acromegaly patients can be normalized, provided that you reduce GH to low concentrations and normalize IGF-1. However, all of these treatments in many cases are oversimplified. In acromegaly, we start medical therapy. We hope to normalize IGF-1, and then we tell the patient you should be fine because the IGF-1 is normal. Just like type 1 diabetes. Start insulin, give a lot, give even more until the HbA1c is normal, and then we tell them you should be fine. But for the patient, this approach is by far not enough, and I'll tell you in a minute why. This is a very essential slide to understand why patients do not always agree the enthusiastic conclusions of the medical profession. This is the mean plasma GH concentrations over the day. The higher, the more RGF1. But that only accounts for the relative low GH concentrations. Up to a certain level, you see that there is a steep increase in RGF1, but that levels off. And say over 30 microgram per liter of GH over the day, there is no further increase in RGF1. You have reached the maximal generation capacity of a liver. Now, suppose you have a big tumor in a patient. The neurosurgeons operate on the patient and is able to remove this individual, the tumor, by 70%. So it ends up here in the GH production. Now, the surgeon is very proud with the post-op MRI. The radiologist is very impressed. The family is very impressed. But the patient will tell you, sorry, doctor, but I have not felt any improvement. And now you understand, because if you really want to bring down IGF-1, you really have to bring down the GH concentrations or actions to a very, very low level. And not all treatment modalities can do that. So therefore, the combined use of several treatment modalities is often necessary to really control IGF-1, and just not one. Now, I talked a lot about IGF-1 already, and for the ones who see patients, you know that we all assess the IGF-1 as the outcome parameter. In fact, anyone with a very high IGF-1, there's only possible one diagnosis, and that is acromegaly. And as soon as the IGF-1 is very high, whatever treatment you try to do, the only aim is to bring it back to the normal concentrations. Now, IGF-1 is insulin-like. And insulin-like means it looks like insulin, but it has a different action. However, it can still bind to the insulin receptor, although with a 100-fold lower affinity. However, the IGF-1 concentration itself is at least 4,000 times higher than your insulin concentration. And if you use a back-on-the-envelope calculation, this does mean that the hypoglycemic insulin-like potency of IGF-1 is 40 times higher than your own insulin. So you might say this is the solution for type 1 diabetes patients who don't have insulin. However, the only reason why you're not killed by your own IGF-1 because of hypoglycemia is that the IGF-1 is bound to binding proteins, and there is no insulin binding protein. So insulin should have an absolute control over IGF-1. If insulin steps out, for instance, if you for whatever reason don't eat for 2 days, your insulin is very, very low. But if your IGF-1 would remain at high levels, you would be killed because of hypoglycemia. So insulin must have control over IGF-1 and over the binding proteins. And it does do that in a very, very clever way. This is the insulin concentration, and this is the so-called log scale. So every next step is 10 times higher than the previous one, 1, 10, 100, 1,000. So this concentration of insulin is measured at a very specific location, namely your portal vein. So what is the portal vein? It's the vein that takes the blood from the gut and the pancreas and delivers it to the liver. So that is where you have your insulin secreted when you had a meal. because the pancreas secretes the insulin, it shows up in the portal vein and ends up in the liver. Now you see that at the increase in concentration to this level, the GH binding capacity of the liver increases. Now this is a very difficult way to say that the liver becomes sensitive for GH. More insulin, the liver becomes GH sensitive. And when it becomes GH sensitive, GH can start to generate RGF1 in the liver. So indirectly you can say more insulin, more RGF1. But the other way around, less insulin, less RGF1. So therefore insulin in the portal vein controls the RGF1 output of the liver. And that is a very important system. This is a very old publication. What did I do? They investigated diabetic patients and they gave them GH because the patients were not only diabetic, they were GH deficient as well. Now, C-peptide negative patients have C-peptide is part of the insulin molecule when it was still called proinsulin. It is spliced from the insulin after it is secreted by the pancreas. Now, all of the commercially available insulin derivatives don't have this C-peptide. So the C-peptide negative patients are the patients with type 1 diabetes who don't have any insulin by themselves and rely on the injections. Now the C-peptide positive diabetic patients still have some endogenous insulin and therefore they are type 2 diabetes patients. But if you have endogenous insulin being C-peptide positive, it means that there is still insulin secreted in the portal circulation, meaning that the liver remains sensitive for GH. And in that case, if you start to give GH for a week, you see that the RGF1 increases here in orange. If there is no portal insulin in the C-peptide negative patients who are treated with insulin in the subcutaneous region, the RGF1 does not come up. So even in the presence of additional GH, you will not generate RGF1 if there is no insulin in the portal circulation. So no portal insulin, no RGF1. And this is very important to understand what's happening in the acromegaly patients. So the GH induces RGF1 only when insulin allows it to do that. Now, if we start to treat patients with somatostatins, we tell the patients that somatostatins work on the pituitary tumor. The pituitary tumor stops making too much GH, and therefore RGF1 might normalize in about 50% of patients. However, somatostatins also decrease insulin and therefore make the liver GH resistant. Also, somatostatins have direct effects on the liver that are independent of GH. So what is the consequences of that? Now, two studies about 10 years apart did about the same. They gave GH deficient subjects on a stable dose of GH replacement for at least a half a year, octreotide, 3 times a day, 50 microgram, sub-Q. That's not a lot. And they measured RGF1 before the week of injections of octreotide and after. So any change in the RGF1 must be GH independent because GH was given at a fixed dose and the patients themselves did not produce GH by themselves. And what they saw is that after 1 week, IGF-1 was reduced by about 20%. So what does this tell us? Octreotide, lanreotide, pasireotide decrease IGF-1 by the liver by about 20% already, which is completely independent of the GH of the tumor. Now, what does this all to do with treating patients and understand what you do with them? In the normal situation, this is you or a patient, the house is your whole body, and this is GH. Well, if you have a normal GH, GH works on the liver, the kidney, the bone, other tissues, and the brain. And in green means that's a normal activity of all of these tissues. And we measured all of these activities simply by measuring IGF-1 that is produced by the liver. So you have to realize that if we measure GH activity, we focus only on one organ and we simplify the effect of the other organs by assuming that the effect is the same. Now, if you have active acromegaly, the GH is too high. Now, GH works on the liver, kidney, bone, other tissues, and brain. So all the tissues, in fact, are too hot when you compare it as an example of, for instance, a heater. Now, again, we measure that by measuring the output of the liver, and we see an increase in IGF-1, and then we say the patient has active acromegaly. So far, so good. But then, let's see what we do with the somatostatin treatment. We say that somatostatins decrease GH, and GH will be reduced. And therefore, because somatostatins also decrease the liver IGF-1 output by already 20%, we overestimate the efficacy for the whole of the body because we measure only the liver. So while the liver is normalized when we measure IGF-1, the rest of the tissues still have a low-grade active acromegaly. So the situation has improved, but not normalized. And patients feel that. So when the somatostatins normalize IGF-1 and the treating physician says, I have cured you for now because the IGF-1 is normalized, that's half true. What in fact has happened is that the liver is under control in active acromegaly, but the other tissues still have a bit of acromegaly, and that is what we now call extrahepatic acromegaly, meaning the acromegaly outside of the liver, which is still ongoing. And patients still have a low quality of life, and the bone still has a progressive arthropathy and osteopathy, and that kills the skeletal joints in the end. While still, the patient and the doctor are convinced that the acromegaly is under control. So if I have to make a guess about the future, GH receptor antagonists will be used in most patients on somatostatins, even the ones that were normalized under octreotide, lanreotide, and pasireotide, as they have the extrahepatic acromegaly. Now, extrahepatic acromegaly is the condition in patients using long-acting somatostatin analogs that have a normal IGF-1 but still encounter increased GH action on other tissues than the liver. Signs and symptoms of this, oh, there's a typo, extrahepatic acromegaly are sodium and water retention related, arthralgias, headache, and a poor quality of life. So if you forget that, just get yourself a package label of GH for GH deficiency. It says side effects that you can see when you start with a dose too high: arthralgias, sodium and water retention, hypertension, headaches, and poor quality of life. So this indicates that these signs and symptoms that are related to too much GH make the patient aware that they are not there yet, while the doctor is convinced, looking at the normal IGF-1, that he or she is already there. So the bioassay quality of life might be a better marker of disease activity than serum IGF-1. And what is the bioassay quality of life? Well, that is something that you can measure now by questionnaires. And a disease-specific one that is used almost everywhere now is the Acromegaly. It was developed by Susan Webb in Barcelona in Spain. But we did already a study before that when there was no Acromegaly available. And the other one that was already available, but that was not disease-specific, was the San Francisco 36 questionnaire. What we did, we looked at patients with a normal IGF-1 under somatostatins. And we did split them up in patients that felt great versus the one that said, okay, I have a normal IGF-1 but still feel bad. Those were the one in the red. They were indistinguishable when you look at their IGF-1, but they felt very different. And we gave them their monthly injections of octreotide or lanreotide. But what we did is we skipped one injection here and one injection there. So this is 4 weeks, 4 weeks, 4 weeks, and this is 8 weeks interval. And then we moved on again. And then we stopped for a longer period of time, and we noticed that the happy ones became unhappy again. Meaning that something happened when you stop for a longer time that reduces the happiness and makes them the same as the unhappy ones. Now, this is what we did. We looked at the IGF-1 that was normal during the treatment. The unhappy ones tended, after one single injection missing, tended to have a higher IGF-1 than the ones who were happy. However, I have to go up one again. All the happy ones escaped, indicating that they still had active disease. But when you look at the mean GH levels at all of the time points, the unhappy ones had a significant higher GH level, having the same IGF-1. And this is a strong indication that patients feel their GH and not their IGF-1. And while we say you should be fine because you have a normal IGF-1, we should in fact measure also their GH, and that tells us much more about their quality of life. That was confirmed by another study, a Danish one, where they compared patients after the treatment that ended up with a normal IGF-1. These in the black bars were patients that were treated by a surgical intervention and ended up with a normal IGF-1 after surgery. And these individuals were treated with a somatostatin analog that effectively normalized their IGF-1. What you see is that having the same IGF-1, in the black bar, the patient treated with surgery had a GH twice as low as the ones that were treated with the somatostatin analogs. And that also could be translated into a significant higher incidence of headache and joint pain in this patient assessment score of the quality of life. Another way of assessing the quality of life. Now, what you see here is what pegvisibant is doing. this is an increasing dose of pegvisament. So for instance, this is once daily 10 milligram, 15, 20, 30, something like that. Now, at the lower dosages, you already block all of the GH receptors in other tissues, in this example, the kidney. But you need a higher dose to block the enormous number of GH receptors in the liver, and by doing that, then you start to see the decrease in IGF-1. If you do this in this model of active acromegaly, the house model, so to speak, the GH receptor antagonists, they start to block the extrahepatic as well as the liver tissues. Because of the efficacy of the lower dose, you see that other tissues are already normalized before the liver shows the necessary decrease in IGF-1, and then you need more of the GH receptor antagonists before finally you see a normalization in the liver. But by doing that, you could end up with a situation where you give so much that the kidney and the bone and other tissue become GH deficient. Have we seen that, or can we measure that in everyday practice? No, unfortunately not. And maybe this is a betterish situation than still having too much GH action that we see during somatostatin treatment. However, the take-home message is, if you only look at IGF-1 normalization in somatostatin-treated patients versus patients treated with pegvisament, you now understand that the metabolic situation for the whole patient and the whole body and all of the tissues is very, very different. So, quality of life in acromegaly patients during long-term somatostatin analog treatment with and without pegvisament. Now, I already indicated to you that the extrahepatic acromegaly could be a factor that is present in quite a few of your patients, in whom, by treating them with somatostatin analogs, you have achieved a normal IGF-1. So again, this is the extrahepatic situation. Somatostatins have normalized liver output by IGF-1, but they don't reduce enough the GH effect, so the other tissues are still slightly acromegalic, extrahepatic acromegaly. If we then start to give low-dose GH receptor antagonists, low means you only decrease the action in other tissues, but not enough to change the liver IGF-1 generation, you might really help the patients a lot. So by doing so, you normalize the complete situation. Is that a problem? No, because this low dose is not enough to change the efficacy and the effect on the liver IGF-1. This is a complicated slide, but what we did, we had 20 patients, again with a normal IGF-1, under long-term treatment with somatostatins, and they kept doing the somatostatin treatment for the whole period of 4 months. We gave them pegvisament on top of the somatostatin treatment. There was a washout, and then they moved on with placebo for another 3 months. The placebo group switched after a washout, and then they got on the second leg pegvisament. And what we saw in this acroqual, higher means a higher quality of life. That if you, on top of your somatostatin, give a little bit of pegvisament, you see a significant increase in the quality of life. This is the washout, and during the placebo arm, nothing happened. The persons who started with placebo and then had a washout and then got low-dose pegvisament, immediately saw an improvement in the quality of life. Now, this was placebo controlled, so we as doctors nor the patients did know when they received the placebo or the paclitaxel. However, I was astonished that all patients immediately could tell me after the study, I had it and then stopped and had a placebo, or the other way around. So patients immediately felt a very significant difference, an improvement in quality of life. And this is the percentage of baseline in the physical dimension of the quality of life assay, again, even showing a more significant change. So patients felt great. However, if you then look at the reason why they felt great, we have to understand again the concept of extrahepatic acromegaly. This is the change in body weight in kilogram in already the first month. Some decreased 5 kilo, which is about 10 pounds, after a month, and those had the most impressive increase in quality of life. Now, if you lose 10 pounds or 5-6 kilo in a month, that means you lose water, because you can't lose 5 kilos of fat in a month. So the GH effect that was still ongoing, the acromegaly of the kidney, so to speak, resulted in sodium and water retention. If you block that with low-dose paclitaxel, you lose the sodium and therefore the water, and you lose body weight, but you improve in the quality of life. Now, doctors will say, oh, that is because you decreased the IGF-1. No. In the placebo and in the paclitaxel period during the study, the IGF-1 levels did not change. So as a doctor, I would tell the patient, we didn't change a thing because we did not change the IGF-1. It was normal, and it stayed normal. So nothing changed, but the patients felt a dramatic improvement. So again, the concept is somatostatins work great. They reduce tumor size in most patients, and at least they control tumor size. Paclitaxel doesn't interfere with the tumor size, and they normalize IGF-1 in about 50% of patients. However, do realize that the rest of the body during somatostatin treatment, in quite a few cases, still has low-grade acromegalic activity. And you can help the patient a lot by adding low-dose paclitaxel that protects the other bodies, the other tissues, against this low-grade acromegaly activity, the extrahepatic acromegaly. Now, to show you how important this system works and how important insulin is for this whole system, again, somatostatin-treated patients, the ones that have somatostatins but still have too high IGF-1, about 50%, have an increase in IGF-1 because the liver still makes too much IGF-1. But in the beginning, I told you no portal insulin, no IGF-1. So how can we reduce portal insulin concentrations? Well, you and I, if you are not have diabetes, we decrease insulin if we don't eat carbohydrates. So what we did is we had a concept that if insulin is low, the liver will become GH resistant because of the low portal insulin concentrations, and IGF-1 will be normal. Now, if IGF-1 decreases in you and I, GH will go up, but these patients receive somatostatins, so somatostatins will inhibit increase in GH, an unwanted increase. And that is what we did. So what we did is we gave acromegaly patients receiving somatostatin treatment, but their IGF-1 still elevated, eucaloric, and explain in a second what it is, very low carbohydrate ketogenic diet, a super Atkins diet. So we had the dietitian, and it was a she in this case. She asked the patient, what do you eat? How much calories do you take? And then she prescribed a diet with the same calories, a eucaloric diet, but she removed the carbs out of that diet and replaced that by extra proteins and fat. So these individuals, by having the same amount of calories but not with carbs, had a significant reduction in their own insulin secretion. And if you do that, you probably, and that was the proof of concept, these 2 weeks was had a purpose to decrease endogenous insulin. And that should make the liver GH resistant, so we anticipated that IGF-1 would decrease. And the expected increases in GH would then be controlled because of the presence of the somatostatins. And that's in fact what happened. These are the IGF-1s, all elevated, some just a bit, but some a little bit more. And after 2 weeks, all of them, except one, normalized with this specific diet, except one, and I'll tell you in a minute what was happening there. And the GH concentrations did not change significantly. And that is because they still use their somatostatin treatments. And if I go back one, this individual already in the blood had keto bodies, indicating that she already had a ketogenic diet, and therefore she did not respond because apparently she was not sensitive. Currently, we do a study where we gradually start and increase the carbohydrates in the diet to see whether there is a kind of a threshold above you again secrete enough or too much insulin in that case, so that the liver becomes sensitive again and that the IGF-1 will increase. So, to round up, when patients try to tell you that they are not okay, they might be right, no matter what the lab results tell you. Even the ones with a normal IGF-1 and a low quality of life, they are right. Don't tell them you must have something else, go to your GP. No, they might have what we now call extrahepatic acromegaly. If the lab results don't explain why patients still have problems, take a chair and talk to them as long as it takes until you understand the problem. And endocrinology, to me at least, and I hope to you, is big fun. And with that, I stop sharing, and we will answer question at the end. And now I give over to Chris, and she will start sharing her screen.
Okay, that was fantastic. Thank you so much, Professor Vanderlei. Lily, I learned a lot. So from here, we go to my friend and colleague, Christine Yadanek. She is a doctor of nursing practice and board certified nurse practitioner. She is an associate professor at the Northwest Pituitary Center in Oregon Health and Science University in Portland, Oregon. Here in the USA, she has provided clinical diagnosis and management of patients with pituitary adrenal dysfunction for the last 20 years. So take it away, Chris.
Thank you. So that was fabulous. Thank you very much, Professor Vanderlei. It was a perfect introduction to where we need to go in terms of nursing care and the basis for understanding what it is that we're doing, why we're doing it, and maybe what we can do a little bit better. These are my disclosures. So I'm going to use the competency framework as was introduced for both nursing, care of testing, and also the treatment of patients with acromegaly. And we'll look at some examples and the knowledge and skills that are needed, both for career development and for potential outcomes for patients or improving those outcomes. So to begin with, a little bit about the competency framework that was developed. Actually, it started to be developed in about 2011, and the effort was led by Nikki Kiefer in UK and supported by the Society of Endocrinology, and the Nurse Committee developed and published their first edition in 2013. And what this does is progressively integrates knowledge, skills, values, and judgments and applies it to specific endocrine disorders. And in this case, we're going to apply it, of course, to acromegaly. So the whole premise was based on Patricia Benner's novice to expert theories, and that to become an expert, there's multiple stages from competency through proficiency to the expert level. When you look at this, you can apply it actually within specific roles. For example, for a registered nurse, for what we call in the United States, a licensed practical nurse, or you can apply it to advanced practice. So I'm actually going to look at this from a novice nurse and then develop it through advanced practice. So this is an example. We don't have time to go through all these details, but what I tried to do was to summarize this for you in terms of the steps that are prescribed by Nikki Kiefer's panel: competent, proficient, and expert level. And I did that by putting it into this framework for each of those levels, the novice, the proficient, and expert. Describing and understanding the background helps with education, both patient education and staff education. And then support and safety features for each are extremely important. And then, of course, documentation. So I made this little acronym, BEDS. So it's best, not best, but just to help to kind of guide that development. The background, of course, is for testing is mechanisms of GH production and suppression. And Dr. Vanderlei gave us a great presentation about how GH is produced. So we won't go back into that description. We'll talk about it specifically with respect to testing. So background for patient preparation and instructions is really important. So we'll also talk then from the novice perspective about issues to address with patients prior to and during testing, and then of course documentation. So measuring GH, why can't we just measure a GH level? And the answer is pretty simple. And it's really not produced in any great amplitude or amount during the day. It's produced in the majority when we are in slow wave sleep. So specific types of sleep will produce higher amounts of growth hormone. So at any point in time during the day, if you would like to measure growth hormone, at sometimes you're going to find that the growth hormone level is actually very low. But during slow wave sleep, it's the highest, and people usually don't get measured during that period. When we're hungry, we produce more growth hormone. And as you see here, there's a little difference between, sorry, the males dropped out here. Oh no, there's males. Males and females are a little bit different in the amount of their production. And of course, stress also. And this kind of is the 3 o'clock hour when mums are trying to pick up kids and ferry them around places. So stress will increase your growth hormone, but that's also not a very good time to measure the growth hormone. The other important feature about measuring growth hormone is that it doesn't last very long in the blood to measure. So between 11 and 19 minutes. So you have to be very lucky to be able to catch that peak right at the right time to say that this person has acromegaly or too much growth hormone production. So as Dr. Vanderlei discussed, the GH from the pituitary circulates not only to most organs of the body, but to the liver, which then produces IGF-1. IGF-1, thankfully, lasts for a much longer time in the body, about 15 hours. So it's stable and it can be measured in any time. There's no specific time that is better specifically to measure this. So fasting, we know that fasting also increases the growth hormone level, and that's really important. It does two things. It also increases the use of adipose tissue, but it also, if there's too much growth hormone, lays down more adipose tissue. So all of this is really important in terms of patient education and instructions. And the rationale for testing is we need to have the patient fast. So the patient fasts, we tell them that they need to fast for about 8 to 12 hours before testing. Testing itself will take about 120 minutes. It's usually very well tolerated. However, they have to understand also that an IV cannula needs to be placed. And in terms of that development for a novice nurse, understanding how to place effectively without creating too much stress, an IV cannula is also important. So practice and mentorship is very important. The patient is then given an oral glucose drink of some variety. There's several different flavors. 75 grams is the usual dose. That's adjusted dose per kilogram for a child. So if you're testing for children, then make sure you calculate that dose effectively. So in terms of safety, fasting is very important. Pregnancy, assuring that that patient has fasted is really important. So we want to make sure that this test is as accurate as possible. So asking the patient, how long did you fast? What was the last thing you ate and when? Often that answer is very different based on the patient's perception. Is the patient pregnant at the time? What daily meds are they taking? Particularly are they females taking oral contraceptives, because that can potentially affect the accuracy of that test. Did they take any other medications that morning? And really be very cautious about documenting everything that was taken. During the test, they may experience some nausea, but also it's important to be able to know the age of the patient, so documenting very clearly the patient information. Have they had any history, for example, anorexia nervosa, which can affect the growth hormone levels? Do they have any chronic hepatic disease? As we know that the liver is very important in that production of growth hormone, or IGF-1 rather, not growth hormone. Do they have diabetes, and is it controlled? And did they take any diabetes medication, or do they take any diabetes medication? Are they hypothyroid, or do they have a thyroid dysfunction? What is their BMI? So weighing the patient and doing vital signs prior to this test is important. Oral estrogen agents, as we talked about. And do they have any issues with kidneys? Kidney failure in particular, so that we need to understand that there's a difference in that test and interpretation of the test if they have some kidney dysfunction. Documentation is an accurate documentation is extremely important. Obviously, all the patient information needs to be recorded. The patient name, the patient age, the record number, medical record number, the date of the test, the vital signs, what the blood pressure was at the beginning, a heart rate was at the beginning, what is their weight so we can calculate, and height so we can calculate a BMI. And then the time point at which this is drawn. So IV placement is usually first, the baseline levels are drawn, and then the administration of the glucose. So the timing of that then needs to be recorded. and then the timing of each particular draw, 30 minutes, 60 minutes, 90 minutes, and 120 minutes. It's very, very important then that the labels be accurate when they're submitted to the lab, with the date, the patient information, the time point of the draw, and the time of the draw. Accuracy in this test is vital. The signature of the person who's done it, the time it was sent to the lab can be important because we need to understand what the glucose level was. And so glucose can be degraded if it's weighted. It's been too long until it's been processed. So the time that was sent to the lab is important. And then the post follow-up labs, vital signs, particularly if the patient has any reaction or any symptoms. And that should be recorded clearly in this column. Now, there are several different presentations for this, and every organization may have a different approach, but these are the essentials to include. So the nurse expert may then interpret this test, looking at the time point and looking at the values based on this patient's BMI, for example, at 28 is a little bit high, but is less than 30. So we consider that as less impactful on these levels. This patient, his baseline level was 1.5, and he really didn't have a significant change in his GH. His glucose did go up, but it should have technically suppressed this, as we talked about, as Dr. Lily talked about. It should have depressed this GH level, which in this case it did not. So when we're interpreting it, remember that it's important to understand those factors that we discussed before. Is the patient, let me just go back one here. No, it's not going to do it. So is the patient anorexic? Do they have any chronic hepatic failure? Do they have any diabetes, etc.? All this from the nurse expert perspective needs to be considered as they're interpreting this test. So we're going to switch a little bit in terms of the diagnosis and management, but there are clinical guidelines that are available, and the proficient or the expert nurse should really understand those guidelines and be able to access guidelines. Serum as IGF-1, as we talked about, has a half-life of around 15 hours. IGF-1 is normal, and the GH level is less than 2. Sorry, GH was left off there. 2 nanograms per milliliter, and acromegaly is basically excluded based on this test. Abnormal, if it's abnormal, we've got to consider the age and gender of the patient, because there are different levels that are considered normal or abnormal based on age and gender. GH suppression test, of course, is done if it's abnormal. And then if the nadir, the lowest level with hyperglycemia, is greater than 1 nanogram per mil, then acromegaly is considered diagnostic for acromegaly, and then we would perform an MRI. If there is an indication or a tumor found on MRI, then the first line recommendation would be surgery. And post-operatively, we would want that OGTT again, and it should be less than 4 nanograms per mil. If it's not, the medical therapy is usually recommended. And it could be that if there's tumor growth, or if we're unable to normalize with medical therapy, debulking of that residual tumor may be necessary. So remember, there are a number of considerations and controversies, and the expert nurse should consider this when interpreting this test. Falsely high levels may be related to the assay itself. There are different variabilities in the assays and sensitivities, and some data says that the GH may in fact be 2 to 3 times higher in some lab assays. So knowing what that assay is for your lab is really important, where you send that assay to. Chronic liver disease, as we talked about, can impact those levels. GH levels may also paradoxically increase in patients with acromegaly in response to glucose. And also for those adolescents, in mid-stage adolescence, we may find the same kind of phenomenon. The nadir for females is often a little bit higher, particularly those on oral contraceptive pills. So it's really important to understand if the patient is taking oral contraceptives. Age adjustment for a cutoff. We don't at this point in time have an age adjustment for cutoff, and we know that aging actually decreases GH levels. And so we treat at the moment all patients, despite their age, by the same cutoff. So also BMI can affect GH levels. It can actually lower the GH levels if it's greater than 30 kilograms per meter squared because of higher metabolic clearance. And also that cutoff, as we talked about before, the 1 UG per liter may actually be affected by the assay that's used. So again, it's very important to know what assay you're using and the accuracy of that assay. So let's switch now to looking at treatment. This again is the competency for treatment. And I've used the same parameters, background, education, support, safety, and documentation to examine this. So looking at background, the novice really needs to understand that feedback mechanism. So feedback mechanisms control the production of growth hormone in normal patients. However, in patients with acromegaly, that production can be what's called autonomous or not dependent upon that feedback mechanism. The feedback mechanism actually fails. It's also important for the novice to know that GH production, as we talked about, is erratic. It happens at different periods during the day, and of course the higher amplitudes, as we talked about, at night. And IGF-1 norms and GH norms are very important to understand that they're age, gender, and lab dependent. So we understand the pathologic changes that occur, and that was well described again in Dr. Vanderlei's presentation. The bones, the brain can be affected, joints, muscles, etc. So understanding those pathologic changes and listening to the patient's description is very, very important. We need to be able to outline that treatment process to the patient at a novice level. So understanding that once the diagnosis is made, then the patient will move through different steps in that process, maybe before surgery, and then maybe need further treatment after surgery. And we'll talk a bit more about that in just a moment. At this point, with the diagnosis, the patient often feels alone, and the novice or the proficient nurse really needs to understand where to connect that patient. There are multiple organizations that are very helpful in connecting patients and useful in helping them, guide them through this process, and simply listening and making them feel not quite so alone, and also providing good patient education. So there's acromegaly support in the UK, there's acromegaly community in the USA, there's a pituitary foundation in most countries. WAPO is the World Affiliation of Pituitary Organizations, and they represent many organizations around the world. So refer patients to these organizations that are known organizations that can help support them through the process. Identify and discuss treatment adherence. Now, how are they adhering to treatment? What problems are they having? What are the challenges? What type of side effects are they having? Often the patient will sit and talk to the nurse and give them that information that they can then report to the team. And they may not feel comfortable at times talking with the team. And again, it's really important to document everything that the patient has expressed. In terms of the expert nurse wants to use a lot more evidence-based in education, but they're not only educating the patient, they're educating the family, they're educating the staff, and this to a large degree happens at all levels again of expertise. Common questions are answered again in that framework, within the evidence-based framework, and we'll talk about those as we go through in just a moment. So assess for comorbidities. It's really important. We know that there are a number of comorbidities associated with acromegaly. And so assessing for joint discomfort, for cardiovascular disease, et cetera, as we talk through this in just a minute. Nurses at expert level often will prescribe, particularly the APPs with prescriptive privileges, and they need to then continue that monitoring and consult with the team as needed for the overall GH suppressive therapy regime. And then also identified gaps in clinical knowledge and research, because at the expert level, we would start to expect to see nurses be able to develop some protocols of their own and understand the research process in more detail. So firstly, in terms of staff education, I think one of the most important things that I see is these photographs are in every journal that I have ever read, every textbook, and they're very important photographs to document the outcome. And these photos in particular demonstrate the progression of this disease if it's not identified and treated very early. However, the acromegaly community provided me with this photo, and these are the faces of people with acromegaly. They're not always the faces that we see in the textbook. So it's very important to understand that as we're educating our new staff, as we're educating physicians, as we're educating nurse practitioners and advanced practice providers, we let them know that this is a late outcome. So I've had patients, unfortunately, tell me, I went to my PCP and we talked about the fact that I have all of these symptoms of acromegaly, but I was told I don't look like somebody that has acromegaly. So remembering that acromegaly doesn't have to be diagnosed at late stage, it needs to be diagnosed early. So why do we educate patients? We want to also reduce their anxiety. We want to improve treatment adherence. But more importantly, on average, any patient, acromegaly patient, whatever disease, there's average about 2 hours of medical consultation a year. There are 8,760 hours per year. So that leaves them with 8,758 hours of self-management. Patients manage themselves more than we manage them medically. And so it's really, really, really important that they have lots of expertise and lots of information, and that we are resources for them in terms of what they need to be able to provide their own care. So principles of learning are important to understand. There are times at which key information is better transmitted to the patient, particularly in periods of strong emotion. But during those times, only limited information can really be absorbed. So at the time somebody has been told that they have a pituitary tumor and they likely have acromegaly, is not the time to give detailed information. It's the time to give very brief information about this can be managed, this can be controlled, and I'll answer some of those questions as we go through this in just a minute. So understanding what the learning style is of the patient. Do they learn by listening? Do they learn by watching? But more importantly, using multimedia, and there's lots of opportunities to do that, both written and electronic at the moment. And they can be referred to really good sites for disease information. Every time the patient is seen, information should be reiterated. So repetition has been shown to be very, very important. Also, I encourage people to bring a family member or a scribe, because memory is very short, and the patient is not necessarily paying specific attention to details. They're paying attention to things that are emotionally strong and impactful for them. And so bringing a scribe that can actually go through that information later is very, very important. So addressing these fears are really, really important first up. So the first question a lot of people ask me when they're told that they have a tumor is this cancer? And in fact, less than 1% of cancers, pituitary tumors are malignant brain cancers. So looking at the imaging is also characteristic of either cancer or non-cancer, and usually you can reassure the patient that looking at the characteristics on imaging, this is very, very unlikely to be a cancer. We do consider cancers in metastatic pituitary carcinomas, so 1.9 to even up to 50% can be metastatic from lung and breast, 3 to 5% kidney, prostate, and colon. So it's still very uncommon. However, we usually are more concerned about those metastatic type cancers. Usually the next question then is, well, what caused it? Did I do something to cause this? And in fact, most of the time, these are just erratic or somatic type mutations, genetic mutations, and they may be very rarely chromosomal or genetic mutations. So is this hereditary? 5% are hereditary or germline mutations, and that includes the familial isolated pituitary adenomas, multiple endocrine neoplasias, and X-linked acrogigantism. But I think that let's watch this space, because we're learning a lot more about the chromosomal changes and genetic changes that are occurring. So there may be in the future a little bit more. I usually ask patients to bring photos, family photos, particularly if they've had a family reunion, so that we can look back and see if there's any features in any of the family members, or did a family member die early. Fertility is really important to a lot of females, and normalization of IGF-1 and prolactin level in particular often normalizes the ability for a pregnancy. Preservation strategies may be necessary in aggressive tumors, and then we may want to refer patients. Morbidity, visual effects, and hypopituitarism. Females usually have lower remission rates, and so those are issues to consider, particularly if there's larger tumors. We talked a little bit about mortality. Mortality is, since about 2008, seems to be normalized, and so that's not as big a concern. Slight increase for women, and no increase with large recurrent tumors or post X-ray or radiation therapy. And there's a higher risk of CVAs in uncontrolled growth hormone. We looked at those patients that are uncontrolled with a growth hormone that's greater than 5 tend to have a higher mortality rate, but those that are controlled actually less than 1 in particular less than 0.4 have a better outcome. So we address the comorbidities, and we talked about this a little bit, so I'm not going to go into this in any more detail, and particularly the quality of life, and we need a lot more data. First line information about surgery is really important. Explanation about the process, the fact that they may have a CSF leak, they may have AVP or DI, SIADH, and what the expected outcomes might be. So we don't have time to go through cure and remission, but that's important for people to understand, and also the fact that their vision may improve. Employment prospects are pretty good. Other factors, very quickly, sorry, tumor-specific factors and patient-specific factors. We don't have time to really deal with these, but it's really important to understand whether this is a prolific tumor, and whether it's a silent tumor, and what the granulation pattern is. It could be sparsely mixed, granulated, or densely granulated. It's important in terms of how people respond to treatment. Specific patient factors are really important. So understanding the age, the understanding of the patient, the abilities of the patient, very, very important. Monitoring the patient long-term, apoplexy, CSF leaks, etc., extremely important. Knowledge gaps, there are a number. There's some data in terms of weight management, but at this point we need more. We need more strategies for joint preservation, fatigue, mitigation, etc., as Dr. Vanderlei talked about. So in conclusion, it's a very quick overview, but there's lots of ways that we can use this competency. It establishes standards for practice. It's a progressive understanding and deeper understanding of physiology and how we can respond. We can address patients' fears, expectations, etc., and involve the family is extremely essential. Self-management is paramount. Repetition is paramount for education to support self-management, and the best outcomes are a team effort between the physician, the nurse, the patient, and the family. So thank you. Sorry it was a bit long.
And thank you, Chris. Really, really got a lot out of that. But we do have some questions. And I'd like to just go through these with you guys. We have a question about what other markers for assessing extrahepatic acromegaly are available despite quality of life.
Well, that's a very good question. And there were several attempts, even some that really went far by taking muscle and fat biopsies before and after medication. We haven't found one yet, a tissue-specific one. Quality of life is very sensitive, and what is also quite reliable is the sodium water retention, leading to too much fluid in the circulation, and that translates into headaches and edema and hypertension. So if an acromegaly patient still needs antihypertensive drugs and complains about headache, it's very worthwhile to see whether to some degree there's extrahepatic acromegaly going on.
So kind of along those lines, are there other GHRA antagonists under study?
Yeah, there are 3 companies or research organizations that are developing smaller molecules GH receptor antagonists. None of them have reached the patients. Some are in phase 1, meaning that they are tested out now on normal individuals, but none of them is used in patients. But the results of all of these companies and research institutions, they look great. Yeah.
Okay. So for you, Chris, is there a need to stop OCPs when testing for growth hormone?
Sorry, could you repeat the question?
Is there a need to stop oral contraceptive pills when testing for growth hormone?
I think with caution, yes, or switch to another form instead of oral form. using another form of contraception, it would be beneficial
Make
in
it a
terms
little
of the
cleaner.
accuracy of the testing. Yeah.
Yeah. So I have a question, kind of a clinical. Why do some endocrinologists stop pegovistatin after starting paclitaxel after treatment with an SSA? After the second transvenoidal surgery radiotherapy when IGF-1 is under control. So why do they stop that?
I don't know.
You don't know?
I can
Okay.
only make a guess, but I just don't know. No.
Okay.
Maybe
Okay. Do you
tolerance is
suggest,
one factor, but
would that be more tolerance?
maybe tolerance is one factor, or again, that combo as waiting to see what that combination will do, or waiting to see what monotherapy will do before you add another
Another drug.
another therapy to it. Yeah.
Yeah.
And
Sometimes
so do you,
it's a financial issue. Sometimes in some countries, physicians are linked to certain contracts between their insurance companies and certain pharmaceutical companies. Yeah.
yeah, we see that a lot. So do you
Yeah,
suggest to
insurance
start,
approved.
yeah, oh Lord. Do you suggest to start pegvistamant from the beginning if quality of life is low? And it's kind
Yeah.
of go by what we're just talking about.
Yeah.
If you
Although the
can.
label says that in Europe and in quite a few other countries, you can only start pegvistamant as a second or third line therapy, meaning that you have to start with other therapies as well. Only in the US you can use pegvistamant as primary treatment.
Okay. So what about lipid changes post-treatment? That was kind of mentioned in the last slide. You're a little more aggressive with the lipid management.
Well,
So
yeah, I do that, but not different from the guidelines of the vascular medicine organizations compared to normal individuals. So they don't need additional medication or higher dosages or lower end results. No, just follow the guidelines per country.
there's not a lot of data though in terms of what the long-term outcome is, correct, in terms of lipid changes with normalization of IGF-1?
No, the patients with acromegaly have a higher incidence of cardiovascular diseases, but they are different. They are not atherosclerosis based. So they have cardiomegaly, so they have a bigger heart with hypertrophy, but their coronary arteries are as clean as whatever. They have more cardiovascular accidents and more cerebral vascular accidents. The last one has been shown to be related to radiotherapy in the past. That increases a 4 times higher risk of a cardiovascular, as a cerebral vascular accident later in life. And therefore, we are very reluctant to use radiotherapy now in patients with acromegaly.
Okay, well, thank you to both of you, excellent speakers and panelists. I learned a lot. I may be seeing more acromegalic patients than I realize. That slide Chris shared, I appreciate that. So we've got a few slides we'd like to finish up with. Talking about our nurse webinars that are coming up in February, we have a polycystic ovarian talk coming up. And then in June, we have a benign adrenal tumor. And then a year from now, November of 2024, we're going to have a webinar on osteoporosis. And so I'd just like to reiterate the many benefits of ESE membership, professional and personal development, much like we saw today, and education, training, research, networking, mentoring, collaboration, and recognition for the work that you are doing. There's many reasons, and especially in the nursing realm, the membership rate is certainly very reasonable. And early on, it's 10 euros annually, and later on, it is 20 euros for those that are an affiliate society to the European Society of Endocrinology. And we'd like to invite everyone to our Congress in May 11 to 14. Please save the date and join us in Stockholm. And thank you so much for joining. You'll be getting a link for your feedback on this webinar. And I'd like to also let you know that there will be a link on the European Society of Endocrinology website that you'll be able to go back and review this webinar at your convenience. If perhaps this wasn't a great time for you, you might be able to look at it at another time. Thank you very much. I appreciate you being here. And again, thank you to Professor Vanderlily and to Christine Jedinek.
Have a great day.
Thank you.
Sorry, I was
Thank
too
you.
long-winded.
Loved every minute of it, Chris. Thanks.
Okay. Talk to you later.
Thanks.
Okay.
Okay, bye-bye.